Okay.
Good afternoon, everyone. First of all, I would like to thank the organizing committee for the kind invitation to present today. It's a pleasure to present on management of heart failure in adults with congenital heart disease during this annual conference of the Pediatric Cardiac Society of India. I'm working as a congenital cardiologist in the University Hospitals Leuven, Belgium, together with my colleague, Professor Gewillig, who presented earlier today. I have no conflicts of interest to disclose. Before we tackle the topic of today, which is the management of heart failure related to congenital heart disease, I think it's important to emphasize that the burden of heart failure in our adult congenital heart disease population is rapidly increasing. As you can see on the left part of the slide, and this is data from the Brompton Hospital in London, United Kingdom, you can see that heart failure is by far the leading cause of mortality in our patient cohort, actually accounting for 40% of mortalities of our total patient number. Not only is the prevalence of heart failure related to congenital heart disease rapidly increasing, its costs related to heart failure hospitalizations, use of ventricular assist device, and the need for transplantation has also quite dramatically changed. And this is data from the United States. Over a 10-year period of time, we see a 50% increase in cost in heart failure related to congenital heart disease, which is not observed in heart failure that is not related to congenital heart disease. In contrast, and this is a bit worrying, despite heart failure becoming more prevalent in congenital heart disease, the use of ventricular assist device has not changed in congenital heart disease, in contrast to heart failure not related to congenital heart disease, and the use of transplantation has actually decreased in contrast to heart failure not related to congenital heart disease. In our own patient cohort, and this is almost 4,000 patients with the last clinic visit after 2010, we performed a case control study, and we saw that having a heart failure diagnosis in a patient attributes to a 5-fold increased risk of all-cause mortality during follow-up in our patients. So having heart failure actually matters. Since we know that heart failure is prevalent, is increasing, and is important, I think it's very important to think about who is actually at risk of developing heart failure. Again, looking at our patient cohort here in Leuven, we see that in patients with cyanotic congenital heart disease, patient with Eisenmenger syndrome, patient with a Fontan circulation, patient with a systemic right ventricle have a quite high prevalence of heart failure, which rapidly increases with age. And for example, in patients with a Fontan circulation, virtually all patients older than 50 years will have some form of Fontan circulatory failure. In patients with a biventricular circulation and a subaortic left ventricle, we see that the prevalence is overall lower, although it does increase with age and is definitely higher when compared to the general population. Because of those lesions being more frequent, the absolute numbers are also higher when compared to the more rare and complex congenital heart disease lesions. Looking at variables that were related with the occurrence of heart failure in our population, we saw that patients who were older, patients who had a history of infective endocarditis, patients with atrial arrhythmias or a history of atrial arrhythmias, patients who required pacemaker implantation, patients who had end organ dysfunction, which is renal or liver dysfunction, patients with higher New York Heart Association class, higher heart rates, ventricular dysfunction, and higher pulmonary artery pressures were independently associated with the occurrence of heart failure. So if a patient with any of those things presents in clinic, one should always consider the possibility of heart failure in that particular patient and maybe perform additional investigations to confirm or exclude heart failure in that particular patient. Once the diagnosis is made, I think risk stratification is very important, because that will be used to see what patients should be referred for advanced heart failure therapies. And this is data from my time in Toronto, from the heart failure clinic in Toronto, where we saw that having a subaortic right ventricle, a higher New York Heart Association class, elevated B-type natriuretic peptides or lower sodium was independently related to worse outcome in our patients. Obviously, we will also use cardiopulmonary exercise testing and the presence of ventricular dysfunction or the degree of ventricular dysfunction in our patient to risk stratify our patients. The development and implementation of better risk stratification tools is one of the avenues for future research in the field of heart failure and congenital heart disease. Once we diagnose the patient with heart failure, the first thing we should always think, can we structurally optimize this patient? In a failing tetralogy patient, is there the possibility to replace the pulmonary valve? Can we do it percutaneously? Do we need to refer the patient for surgical intervention in order to stabilize or improve heart failure symptoms in that particular patient? In case of atrial arrhythmias, ablation should always be considered, especially in patients with a Fontan circulation and patients with a systemic right ventricle who are preload dependent and fast atrial heart rates and loss of the atrial kick may be worse. It's also important to consider the possibility of resynchronization therapy as well in patients with congenital heart disease. And on the right side of the slide, you see an example of an older patient with repaired tetralogy of Fallot who got his last pulmonary valve replacement in 1976 and had a two-chamber pacemaker in the meantime, who presented with heart failure and atrial fibrillation, and as you can see, had significant pacemaker-induced synchrony, induced pacemaker desynchrony. We were able to improve his heart failure symptoms, his ventricular function, by upgrading his pacemaker to a CRT device. Medical therapy is a cornerstone of heart failure management in congenital heart disease, but I think it's important to realize that the evidence base of medical therapy in congenital heart disease is very limited. Still, I would like to refer to this consensus document published in European Heart Journal a few years back by my colleague here in Leuven, Professor Butz, who, based on ventricular function and which subaortic ventricle, be it a subaortic right ventricle or subaortic left ventricle, made some suggestions whether or not to start classic heart failure therapy in that particular patient. Just showing the difficulties of medical therapy for our patients. These are two patients with a systemic right ventricle. On the left, a CCTGA patient. On the right, a TGA sending patients who reported to be fine, but one presented with sustained ventricular tachycardia, the other one with atrial arrhythmia. And despite reporting few symptoms, if you look at the invasive pressure measurements and the BNP levels, you can see that both patients had significantly elevated end-diastolic pressures, elevated pulmonary artery pressures, and elevated NT-proBNP, suggesting that they had significant heart failure and probably required heart failure therapy and maybe even consideration of advanced heart failure therapies. However, if you look at the evidence base, and we do not have randomized controlled trials, there's almost no studies suggesting any benefits from beta blockers, ACE inhibitors, ARBs, ARNIs, or MRAs, except maybe the study from the Netherlands by Van der Boom, who suggests the potential benefit of valsartan on RV and diastolic volumes. A second group of patients where we're currently failing to provide any evidence of medical therapy or Fontan circulation, and just highlighting 3 patients that I'm following in clinic, also highlighting the heterogeneity of the patients, ranging from patients with very low ejection fractions to patients with normal ejection fractions, patient with no AV valve regurgitation to patient with only mild AV valve regurgitation. But what they all have in common is that they're presenting with Fontan circulatory failure, with high venous pressures and low cardiac output. If we think about the physiology of the Fontaine circulation, and I think my colleague, Professor Gewillig, presented before me, we do know that the primary problem is the pulmonary circulation. This is an elegant paper from Dr. Egby from the Mayo Clinic, performing exercise cardiac catheterization in Fontaine patients, showing that those with a steeper pressure flow plot had worse outcome when compared to patients who had a less steep pressure flow plot. But just look at the limited cardiac outputs that they are able to generate during exercise. So it makes sense to evaluate pulmonary vasodilators in patients with a Fontaine circulation, but up until now, we have very limited evidence. The field trial, which included 400 patients evaluating udinafil, was negative in its primary endpoint. The TEMPO trial, which looked at bosentan in Fontaine patients, was slightly positive, but the improvements reported in peak oxygen consumption range from 3 to 5%, and one could wonder if this is actually clinically relevant. There's the ongoing Rubato trial, which evaluates macitentan in Fontaine patients, but my guess is that this study will be negative in its primary endpoint as well. Obviously, it's not just the pulmonary circulation. We also have secondary problems, and one that we're currently struggling with and incompletely understand is diastolic dysfunction. As you can see, the ones with the steeper pressure flow plots during exercise were also the ones who had a steeper rise in pulmonary capillary wedge pressure during exercise. And I think an important avenue for future research in Fontaine patients is better understand and maybe identify targets for interventions for diastolic dysfunction in these patients. Timely consideration of mechanical support and transplantation is important and should be considered in patients with heart failure refractory to medical therapy, in those who will not benefit from surgical intervention or EP intervention, congenital heart disease patients with life-threatening arrhythmias who are refractory to all therapeutic modalities, but also patients with stage C heart failure who are maybe not as symptomatic, but already developed pulmonary hypertension and have a potential risk of developing irreversible pulmonary hypertension. Fontaine patients with PLE refractory to medical therapy could also be considered, and cyanotic patients with progressive cyanosis leading to functional decline not amenable to surgery or catheter-based interventions. Crucial along the life trajectory of our patient is the consideration of advanced care planning, and if a patient, especially a patient with heart failure, presents with atrial arrhythmias, recurrent admissions to the hospital, one should also always initiate advanced care planning and not postpone this just before the actual demise of the patient. And for further information, I'd like to refer to our review paper published a few years back in International Journal of Cardiology. So, ladies and gentlemen, to conclude, I think I could convince you that heart failure in congenital heart disease is prevalent and has become the leading cause of mortality and morbidity in our patients. Knowing who is at risk of developing heart failure is crucial, because in those patients we could look harder to confirm or exclude the possibility of heart failure. Improvement of and risk stratification of heart failure related to congenital heart disease is important to recognize those who may benefit from referral to specialist care centers for advanced heart failure therapies. Structural optimization and electrical optimization should always be considered. Medical therapy remains a cornerstone of heart failure management, although its evidence base is limited, and timely referral for mechanical support and transplantation is very important. Along the life trajectory, advanced care planning should be discussed with all of our patients. I thank you for your attention and be happy to take any questions.
Thank you.